its close proximity with the brachial plexus and axillary nerve uh, requires a special attention. Okay. So how many of you do open subscap repair? No one? Arthroscopic subscap repair? Okay, good. So there are a good number of people who are doing arthroscopy, but no one is doing open, right? Okay. So I will start with the case presentation directly. So this is a male 55 years of age having history of trauma before 2 months with dropam and belly press signs positives. So pointer chabe. So you can see on MRI. Fine. Okay, okay. LED screen. चलेगा रहने दो कोई बात नहीं. So you can see this format of bicep which is dislocated. This is subscap, right? चल रहा है? Okay. So you can see this is biceps, this is subscap which is torn. You can see subscap which is very much retracted, and this is looks like a part of subscap. But let us see what we can see on the arthroscopy. So this is dislocated biceps which can be seen. So I usually do biceps tenotomy, and in some cases tenodesis on the top or in the groove in young patients in massive subscap tear, because it is difficult to stabilize the biceps even if it is not torn in subscap tear. So this is how it looks. So the entire anterior space is empty. You cannot see a tendon. So now once you just mobilize and give traction, you start to see. So this is the anterior portion where we see normally rotator interval. It is entirely empty. So we are now looking from the posterior portal and working from the lateral or anterolateral portal. So this is the conjoint tendon. Now after initial mobilization, you can see uh, what I am holding is a coma tissue, that is connection between the subscap and supraspinatus. So never cut it down. It is an important structure for stabilization and fixation. So it was very stiff, not coming up to the footprint. So I put a couple of traction stitches in the subscap. So now we are viewing through anterolateral portal and working through anterior portal. So this structure in front is conjoint tendon that is attached with the coracoid tip. So you cannot do blindly release anteriorly and medially in this area because of important neurovascular structures. So in retracted subscap, you need to mobilize from subcoracoid space as well as from the articular side, that is capsular release. So this is subcoracoid and medial to conjoint tendon and coracoid area. So you gradually you can dissect it and you can identify the axillary nerve, and if you go behind you can identify the musculocutaneous nerve. So you use mix of shaver and RF. You can use, so this is shaver. I am doing blunt dissection with the shaver blade. You do not switch on the shaver, otherwise you may accidentally damage the vital structures. So this is the, so you need to go gradually and dissect it out. So this is the posterior cord and axillary nerve arising from that. So you may sometimes identify the musculocutaneous nerve that just lies behind this nerve if it is required. So this white cord-like structure is axillary nerve. So the most important part is mobilization in massive subscap tear. So I usually use 2 anchors in the LT for type 4 subscap tear. So this is inferior and superior, and then once you identify the structures, mobilize it, then the repair is easy. So I will, so that was only the single row repair with 2 anchors. So this is the case 2. Again you can see the massive subscap may be retracted beyond the glenoid with dislocated bicep along with the superior or proximal migration of humeral head. So she is a young female, trauma before 1 month, and she is having pseudoparalysis. So this kind of tear there, these patients deteriorate rapidly. If it is completely torn, there are higher chances of retraction and rapid development of fatty atrophy, and that can create a trouble if you wait for a longer period. So similar technique, you should be able to do out of box repair. So you need to visualize from anterolateral portal and working through anterior portal. So we are viewing from anterolateral portal and working from anterior portal. So the structure above the RF probe is subscap. This one is subscap, and this is the capsular attachment on the humeral head, right? So, and this one is biceps. So in this case, I tried to keep biceps preserved. Biceps was relocated, and I was trying to just fix it.
The hole size is around 5 mm, so you can clearly pass the 5 to 6 fiber wires from each hole. You can also use the tape also. So now we have around 7 to 8 sutures, 4 from the each hole, anterior and posterior tunnel, and they comes out from the lateral aspect of the humerus, 4 anterior, 4 in the behind. So now we pass one by one all the thread from the cuff from anterior to posterior. It looks like a spider web from front to back. So it looks like a spider web. This is a final repair. The main important and main good point is there is no hasslement, there is no hassle for the sutures, because if there is an entanglement for the sutures, they probably sold in the tunnel, because the tunnel is a very big size. But if you pull the suture which passes from the anchors, there is high chances of tear. You may cut through from the suture. So this is a very good repair. So the final repair image. So this kind of X box double tunnel transosseous repair. I usually allow such kind of patient early mobilization, and at the end of 3 or 4 months, they usually get a very good movement. So there are different system for the transosseous arthroscopic rotator cuff repair existing today in the world, from the tensor surgical, arthrocuff, drill bone, Ketor. These are tensor surgical from the USA. These are usually these arthrocuff, which is developed by our own Indian professor Senthil Velan, which works in the Chennai in the MIOT. This drill bone is from the Czech Republic, and the another system is from the Ketor. So influence, this is a very good paper, arthroscopy paper, which suggests if the position of the musculotendinous junction with the respect to the glenoid face with the single row repair, there are our 90% healing rate if the cuff is lateral to the glenoid. But if cuff is medial to the glenoid, there are only around 50% chances of healing rate. So probably high failure rate. This is a very good paper from the Johan Ho recently in the clinics in shoulder and elbow, which suggests that retear rate at the last follow-up in the transosseous group is around 5%, but in the suture anchor group it's around 19%. And the peri-implant cyst formation not observed in the transosseous repair group, but it's statistically significant in the suture anchored patient. It's around 16%. Thank you.
Thank you, Kaushal. Arthroscopic transosseous repair is not as simple as it seems in his slides. Maybe he has mastered the technique. Otherwise, it is very difficult with these all bulky instruments arthroscopically. We are running short of time. So if there are any few quick questions for this particular session. Yes, Bharat.
Yes, sir. Yes. It's very good. There are very less chances of retear and probably end up with the reverse shoulder. Mostly the reverse shoulder occurs due to the high retear rate, but probably we miss such kind of patient in our practice. You can see that there are 40% retear rate, but we never see our patient again with the retear. Probably they go with the another surgeon, or they just stay away from the surgeon.
Vishal.
Normally in rotator cuff tear for rehab protocol, we normally allow the patient to do a passive movement mostly immediately or after 10 days of surgery. But for tendon transfer, I assume that we will not be able to keep the shoulder in a shoulder immobilizer. It might require abduction or in external rotation. So do you keep in there, and what will be a rehab protocol for a tendon transfer patient?
After the tendon transfer, particularly with the lower trap, I usually ask the patient to remain immobile in the abduction and external rotation, particularly in this position. But in my practice, I usually give that shoulder abduction brace for 6 weeks. Probably no any movement from the shoulder for first 6 weeks after the tendon transfer. Only finger, wrist and elbow, and shoulder in the abduction and external rotation for 6 weeks. And after, usually same protocol with the rotator cuff repair, same like rotator cuff repair.
So I think we move to the next topic. I request Dr. Ajay Bharadwaj sir to please felicitate Dr. Kaushal. Ajay Bharadwaj sir is one of the first persons to start arthroscopy here in our city. So
Okay. So after cuff, we move to instability. Next, Dr. Swapnil Nalge for shoulder instability.
Good morning, everyone. I'd like to express my gratitude first of all to Indian Arthroscopic Academy, South Gujarat Orthopedic Association, and Ceronics, the sponsors for the day, to have me over here for a talk on shoulder instability. Myself, I'm Dr. Swapnil Nalge. I practice as an associate professor in Government Medical College and New Civil Hospital, Surat. Uh, I have a talk on shoulder. This is the static stabilizers of your shoulder. I'll repeat: the bony contour, the labrum, and the ligament. Now this labrum and glenohumeral ligament, but they both form a complex that is known as a capsulolabral complex. Because this word we have to be in mind when we are treating this instability patient. They are not different, they are together because attachment is common. And this ligaments, glenohumeral ligaments are nothing but capsular thickening, right? And if you see in a sagittal plane, it looks like this. So there's a biceps tendon from the top. This is the bony part. This is the bony part. This is the labrum that gives concavity, and this is the thickening of the capsule. That is the superior glenohumeral, middle glenohumeral, and if you see inferior, there are two bands. One is anterior, one is posterior, and this forms a hammock for the shoulder joint inferiorly. So going about the dynamic stabilizers, you have glenohumeral muscles around, and you have the scapulohumeral kinematics, which forms the dynamic stabilizers. So my talk today is more about shoulder instability, in which I'm going to talk about anterior shoulder instability, in which I'm going to be more precise on what are the pathology related to the static stabilizers of the shoulder joint. So let's start. The first thing is, if you have this trauma or any kind of eccentric contraction that causes your head to go outside the resistance of this capsulolabral complex, the first thing you might get is a tear over here. That is the antero-inferior aspect of the labral, capsulolabral complex, can we say? So this is the first thing. Now remember, Bankart lesion as such is a soft tissue injury, and it is a soft tissue surgery as well. Second, this is just sagittal view to how it looks, because we need to read our own MRIs. So it is better to know how it looks on your sagittal axial view and how it looks on the sagittal view. Second is ALPSA. What is ALPSA now? You'll see this term commonly written by the radiologist. ALPSA is nothing but the full form stands for anterior labral periosteal sleeve avulsion. After multiple dislocations, the capsulolabral complex, which is normal here, this is Bankart, the capsulolabral complex comes and sticks onto the anterior aspect of the glenoid. And this sticking is known as ALPSA. Third, Hagel. Now remember, the glenohumeral ligament was stretching from the humerus to the glenoid. So it is not always they'll tear from the glenoid. They might tear from the humeral aspect as well. And it's a nightmare to treat. I've done one case, it was really a nightmare to treat this kind of patients. Last is bone loss. Remember, it's an impact injury. When the humeral head is banging on the glenoid, you might have an impact on the humeral head, in which this, abduction, external rotation, this comes and hits over here. So there may be a small indentation or impaction fracture on the posterior superior aspect of the humeral head, what we call as the Hill-Sachs defect. Or there may be a fracture of the glenoid bone itself, which I think Ritesh sir is going to talk about, bony Bankart. So this is about the understanding what the normal anatomy is and what is the biomechanics of the injury as such. I'll proceed to my first case. This is a 36-year-old male, labor union ka some lawyer or something, 3 times dislocation. First time dislocation was while he was riding a bike and he had a fall. The last time dislocation was again while playing some cricket. I always like to ask them how many times dislocation, what was the first episode causing effect, and what was the last thing. I like to always ask my patient whether there was any dislocation in sleep, because dislocation in sleep indicates more towards there is some amount of bone loss. So it's no more a soft tissue injury. Apprehension test standard was positive, the range of motion was full. It is reduced every time by an orthopedic surgeon. This question I like to ask them, because if they are reducing by self, by own, that means there is some hyperlaxity, or there is bone loss, or there is some kind of multidirectional instability. So I keep these questions in mind whenever I'm in talk with the patients. This is his MR, standard MR, axial view showing capsulolabral injury, sagittal view showing anterior-inferior labral injury. A simple case to start with. This is the position I operate my instability patients. I like to ask questions to whom do shoulder instability patients. How many do it in beach chair position? Instability. Anyone? No. Ritesh sir is not there. He was saying in between, he has started doing it in beach chair. Easy position to do instability as such. I prefer doing in this position. I keep a bit more hyperabduction, 40-50 degree. For instability for cuff, I keep around 30 degree. These are my standard portals. This is the acromion. This is the clavicle. This is the AC joint. So this is my standard posterior weaving portal. This is the coracoid and this is my anterior portal and this is my anterosuperior lateral portal. This is the first case I went in and I am watching right now from the anterosuperior portal and you can see the amount of capsulolabral tear on the anterior aspect of glenoid. Went in for anchor insertion. I like to put my anchors more on the face of the glenoid so that I can have more lift of the capsulolabral complex onto the glenoid. These are the threads that have passed through the capsulolabral complex with the help of a lasso kind of device and 2022. So this is couple of years follow up. He's doing well. He plays his occasional, he's a weekend warrior, goes to cricket playing on weekends and is fine with it. Case 2. Now, this is a video not of this particular case, but just I wanted to show how the head in abduction external rotation comes and bangs onto the anterior aspect of the glenoid. So you can see, this is intraoperative live. My scope was in the posterior portal. You can see the head is going and in the anterior aspect of the glenoid, there is a big dent on the posterior superior aspect. Here. It's working? Yeah, it's here. So this case, I just missed. What I wanted to say is there is a bone loss on the glenoid aspect or humeral aspect. In this case, I just wanted to show you how we manage the bone loss on the humeral aspect of the humeral head aspect. So in this case, what we do is we fill that defect on the posterior superior aspect of the humeral head with the capsule as well as the infraspinatus, so that whenever there is abduction external rotation, that indentation would not come and engage in the anterior aspect of glenoid, right? So this surgery is known as the remplissage, which in French means filling up the hole. So apart from filling up that cavity, we also have a tenodesis effect of the infraspinatus and the chances of recurrence shoulder instability comes down. So this is a single spectrum of disease. You may have a capsulolabral complex tear anteriorly and you may have a posterior superior indentation simultaneously. So it is very, very important to treat these conditions together whenever they are present in one patient. So this is the technique how I take the bites from the capsule as well as the infraspinatus. And if you observe, after tying this, after passing these threads to a different aspect of the capsule as well as the infraspinatus, when I pull this, I've not taken the bites yet, but if I just pull, the head is getting posteriorly again, it is coming central onto the glenoid, which is migrated anteriorly. So the remplissage, apart from filling that hole, has a big role in making the head of humerus center onto the glenoid. That's what my personal belief is. Case 3, 26-year-old male, 4 episodes of dislocation. First episode while throwing ball and last while swimming. No dislocation in sleep, hyperlaxity present. This factor I think we have to all consider when you're treating our patients, because if it is missed, we may be in the soup because the surgery might fail itself. What I do for hyperlaxity, I calculate the Bigton score. And for them, I keep the criteria of my surgery a bit, I am more spectacle, I will provide them more some kind of treatment to avoid recurrence. So that's the apprehension test I'm doing. So after going abduction external rotation in some degrees, the patient has pain and he tells not to do it, that's it. I had 2 dislocations in the OPD itself while doing that, it's possible. This is the MR, you can see the anterior inferior aspect of the labrum that is detached. Here in the axial view, again this is the detachment. This is the small indentation on posterior superior aspect of humeral head. So this is again a same spectrum of injury showing capsulolabral tear along with the humeral head indent. I am showing this case to show what happened to the glenoid. If you see, I am coming from the posterior aspect, posterior portal. You can see there is no glenoid here. There is no capsulolabral complex. There is some amount of tissue here. It may be a bone or a labral piece, I don't know. I did this. I went ahead. Now I am watching from top, anterosuperior portal, and you can see the glenoid is totally devoid of labrum or capsule, but there the capsule and the labrum is stuck here. You can see the inferior part here, it is stuck here, there. So this is what we call as ALPSA. So the sticking of the capsulolabral complex onto the anterior glenoid neck is what is called as ALPSA. And these lesions need a very good release, very good release. I'll show you how. So this is my liberator that is coming from the anterior portal. I'm watching to the anterosuperior lateral portal. You can see the release I'm doing. It will bleed. This, when you release it, it is going to bleed. Do not panic. So after doing a good amount of release, I have two criterias for whether I have done enough release or not. First thing, my capsulolabral complex has to float at the level of glenoid. Number one. Two, I like to see my subscapulars through my release. So these two things should be fulfilled. And third, I like to have my grasper or my suture retriever and hold this capsulolabral complex and try to reduce onto the glenoid. You can see now, and you can see the IGHL band getting tensed. So this is my criteria for release, and mind you, a good repair is not possible without a good release. A release is very important. So I have taken the first anchor onto the 530 position. That's my first bite that has come. And if you can notice, there was nothing over here. But look at that. The capsulolabral complex has shifted very nicely onto the, and this is what we call as the bumper effect. Right? So this is the first anchor. That's my second anchor. That the first anchor is here at 530. This is around 330. That's the second anchor coming. And I think we have done a good release and a good bumper that has been created for this patient. I also did a same Rampliss's procedure in this as well. Last case, 23-year-old male, 6-time dislocations, reduced by own twice, last dislocation in sleep, Becton score 6. Now, I have said about capsulolabral repair. I have showed you about how the humeral head bone loss we treat. We also showed how the ALPSA lesion looks and how we treat it. Now with this picture, what do you feel? Do you feel it's a bony defect? What made you think towards it? One is dislocation in sleep. What else? Reduced by own. So there is so much of space that he can reduce on its own. So this history gives me an indication there is a significant amount of bone loss. What investigation would you like to perform in this particular candidate? So we have done an MR. This patient came to civil hospital from somewhere else, and you can see what was written. It's a Hill-Sachs defect. There is a glenohumeral ligament avulsion, suggestion of Bankart. There is a cyst in the humeral head. Mind you, cysts in humeral heads are very common. There's incidental finding. Subtle bone edema, that's it. Now looking at this picture, it was very obvious, capsulolabral repair, it's a Bankart and we might treat it. What happened is, just look at the MR picture, don't see at the reporting. Look at that MR picture, look at this. There is straightening of the anterior glenoid margin. The history, the MR, made me think, and the resident got me this case, sir, ye to Bankart karna hai, kal OT mein post kar dete hain. Right? But this made us think that wait, we have to get an MR done. We first got a CT scan done, sorry. So we got first a CT scan done, and CT scan mein the radiologist over there was not knowing how to calculate, and they did this. They gave me a circle fit method of calculation what is the amount of bone loss, and it came to be 28 percentage. Kaushal bhai, do you feel it's 28? Looking at the gross picture, Nandan bhai, kya lagta hai? Around 20. So we went ahead. I think I said ki no, I want to calculate exactly what is the amount. So the best way to calculate the percentage of bone loss in such cases is to get a bilateral glenoid end face view. Take a bilateral scapula CT scan, take bilateral end face view of the glenoid, compare them and calculate. Now you can see. We went ahead, we calculated the amount of bone loss and it was 32 percentage. And now the planning was important. The execution is easy. The procedure that was done was an open. What was the procedure when we do this? It is a Latarjet. So open Latarjet that was done. We did an osteotomy of the coracoid process and we fixed it with the 2 screws on the anterior aspect of the glenoid. And the patient is doing well. It is 4 months post-op, not a long follow-up I have. The patient is happy. He has full range of motions. Sorry, I don't have a video as well. Grateful to have them in civil hospital, and some of them have got some medals. I would just like to mention Rohan Vakta sir is here. Yeah, hi sir. This patient, one shoulder I have done and recently you have done the second one. Yes, so he plays Kushti for Gujarat and he was very thankful to you. He met me recently. His second shoulder is done by you. So he plays for Gujarat Kushti. Then we have got this weightlifter. Her name is Pooja Raikar, and the last one is Ayushi. She is also a weightlifter, not yet treated. She has a posterior superior labral tear. We have not yet treated her. Thank you so much.
Thank you. That was a very pertinent take-home message. We are running short of time, so if any quick questions, or should I? Yes, Pawan. Mike, please.
Yes, sir.
Posterior tear and superior tear, how it present clinically differently as compared to normal anterior Bankart tear?
So
clinically, only clinical findings.
360-degree tear patients will have apprehension anteriorly, posteriorly as well as superiorly. I personally have not treated a single such patient. I have seen some patients with anterior tear and posterior minor tears. I have done repairs of both, but never had a patient of 360 labral tear. I have just read in literature. Sir, you guys may have experience.
I agree. I think I agree. So, I would like to invite Dr. Nikhil Vajrajani sir to please felicitate Dr. Swapnil Nagle. Thank you, sir. Thank you, sir.
From anterior to posterior, I invite Dr. Nandan for his talk on locked posterior dislocation.
Good morning everyone, and I would be speaking on locked posterior dislocation of the shoulder. So the clinical presentation, this was a 64-year-old diabetic female who presented, who was found incidentally to be in a drowsy state in her room. She stays alone, probably she had a fall. She was admitted, diagnosed with hyponatremia, treated and recovered within a week. Then she started complaining of shoulder pain. I examined her. The range of motion was very painful. So we got an X-ray done. X-ray showed a posterior dislocation. Sadly, I don't have those X-rays. I straight away went with an MRI to know the status of the rotator cuff and the other soft tissues. So this is the MRI which shows a locked posterior dislocation with a deep reverse Hill-Sachs lesion, an intact subscapularis and an infraspinatus. There was some amount of supraspinatus tendinosis with a minor rim rent tear. The glenoid retroversion was at 3 degrees. There was a posterior labral tear which was spanning from 7 o'clock to 12 o'clock. I was able to achieve close reduction under general anesthesia, and these are the surgical steps. So my scope is in the anterosuperior portal, that is the posterior labral tear. A posterolateral portal was established, release of the posterior labral tear. That was followed by creation of the anchor bed. This is the first anchor. Passage of the retrograde passage of the sutures with a little capsular shift to a retensioning. As is prescribed, I use 3 anchors followed by knot tying to achieve a capsular retensioning along with the capsular shift. You can see the capsule being retensioned. Next, focus was shift onto the reverse Hill-Sachs lesion. That is the reverse Hill-Sachs lesion, followed by subcoracoid clearance. I preserved the MGHL, and next we went on to clearance anterior to the subscapularis to do the arthroscopic McLaughlin's for knot tying, and that is the perspective of the subscapularis. This is the creation of the trans-subscapularis portal for insertion of anchor into the reverse Hill-Sachs. That is the anchor going into the reverse Hill-Sachs. I just wanted to fill in the defect. So the anchor never went near the cartilage. It is in the center of the Hill-Sachs. And then that is the antegrade passage of the sutures, the final positioning of the sutures, and the completed repair with the humeral head being centralized onto the glenoid. This is the result of the patient at 6 months. I believe she had a fairly good result considering the pathology. So while treating this patient, I had 4 pertinent questions in my mind which I'll be presenting. So why not leave alone after a close reduction? Why do a McLaughlin's procedure when you can do only a posterior labral tear and deal with the pathology? Why not do an open modified McLaughlin's instead of doing the hassle of a arthroscopic procedure? And why not do an anatomic or a reverse TSA since she has such great amount of bone loss into the humeral head, and doing a soft tissue procedure might compromise. So why not leave alone after a close reduction? So there are 3 risk factors in this patient which indicate a high risk of recurrence, which we do not want since she stays alone. So that was a gamma angle of 90 degrees and above, a labral tear of the entire posterior half of the glenoid, and an old age female. So what is glenoid, what is gamma angle? So gamma angle is subtended at the center of the humeral head with one arm going along the bicipital tuberosity and one arm through the posterior half of the defect or the posterior edge of the defect of the reverse Hill-Sachs. In this patient it was 125 degrees. Again, in these articles it has been mentioned if the reverse Hill-Sachs is more than the 25% of the humeral head articular surface, it is unstable and an additional soft tissue or a bony procedure needs to be done. So why do only a McLaughlin's procedure? Only a posterior labral repair would be sufficient. Again, a gamma angle for more than 90 degrees is an indication for a reverse remplissage or a modified McLaughlin's procedure. This is again a demonstration of the gamma angle calculation, bone defect calculation and the retroversion calculation. Again reiterated in another article where you have 25 to 50% of your bone loss, you need to do a reverse or a McLaughlin's procedure. Why not do a bone grafting for the reverse Hill-Sachs? We have 2 options. One is an allogenic osteocartilaginous bone graft or an autologous iliac crest graft. This is not available in India, has graft rejection and non-union chances with only good results reported in 50% of the cases. With an autologous iliac crest graft, there is an additional morbidity, additional non-union. I am personally afraid of keeping non-cartilaginous intra-articular grafts, and there are no studies comparing soft tissue with bone grafting. Why not do an open modified McLaulin's? Would not be able to address the posterior labral tear. This reduces the moment arm of the subscapularis and some amount of strength and the additional morbidity of an open procedure. Why not do an arthroplasty? I think it would be an overkill. Relatives did not obviously give consent to this. Theoretically, it is an option. I have kept it in case of revision.
Yes, Rohan.
So Nandan, just like a routine bank cut and remplissage, why don't you do first remplissage and then do the posterior labrum? Because sometimes once you close down the posterior defect, the humeral head will shift anteriorly and to do the remplissage would become difficult.
Uh, yes, the thought process is you try to treat all the pathological conditions in one go. You are already operating the patient, why not do a posterior labral repair also? There
No,
is
I understood. What I'm asking, first on table, first finish off passing the threads of the remplissage first,
yes,
just like the routine bank cut remplissage.
yeah, yeah. So that is an option, but I prefer to do it this way.
Okay. Okay.
Yeah.
So I request Dr. Dhiren Maida Sahib to please felicitate Dr. Nandan Rao. Thank you, sir. Thank you, Nandan.
I welcome Dr. Rohit Damor from Ahmedabad for his talk on calcific tendinitis of rotator.
Thank you, Dr. Rohit, for accepting our invitation. And this is a very common topic in everyone's OPD, calcific tendinitis. There are various ways of management, and probably he will just ignite a discussion on a OPD case of calcific tendinitis.
Uh, Thank you inviting me for this lecture. Now I am going to talk on another pathology of rotator cuff, calcific tendinitis. It is a form of tendinitis characterized by deposition of hydroxyapatite in the tendon of the body. This is most commonly seen in the rotator cuff. Clinically, it is more commonly seen in the female ranging from 30 to 60 years of the age. Supraspinatus is more commonly affected as compared to infra and subscapularis. Incidence of bilateral cases are seen in 10 to 25% of cases, while asymptomatic calcification seen in 5% of the healthy adults. Causes are like idiopathic, or it may be due secondary due to endocrine related disorders of the thyroid, estrogen or glucose metabolism. While understanding pathophysiology, it goes through three phases. First is formative phase, second is a resting phase, and third is resorptive phase. It also known as a pre-calcific, calcific or post-calcific stage. The actual mechanism that initiate these stages are still not known, but the number of vessels found at the site of calcifications are very low. So local hypoesthesia caused by tissue hypoperfusion, and which triggers the transformation of tenocytes into chondrocytes. Hydroxyapatite crystals accumulate between this chondrocyte and fibrocartilaginous tissue, forming small calcium deposits. In first phase, the calcifications have chalk-like crumbly consistency. During resting phase, the calcifications are liquefied and change into toothpaste-like consistency. In third resorptive phase, this is initiated by increasing vascularization around this deposit, and the macrophage and the giant cells surrounding it form granuloma in which the calcific deposits are resorbed. This leads to formation of scar tissue in the course of remodeling process. During the clinically, during the formative and resting phase, the patients may be completely asymptomatic or mild pain is there. This stage lasts from 1 year to 6 years. Acute and severe pain is typically seen in resorptive phase that may extend from 3 weeks to 6 months. The resorptive phase causes local edema and leads to increased pressure within the tendon substance, and this triggers pain. Acute pain also occurs due to rupture of this calcium deposit and irritate bursa leading to inflammatory bursitis. It is easily diagnosed by X-ray or ultrasound and MRI. While managing this kind of patient, conservative measures are successful in most of the cases by giving rest, physiotherapy, anti-inflammatory medicine, subacromial corticosteroid injections, or ultrasound-guided lavage. Surgery is only required for if pain is not controlled by this conservative management, and arthroscopic management is preferred because of its minimal invasive nature. This is the case of 32 years old female patient with complaint of severe shoulder pain with spontaneous onset. She gone through 3 months of failed conservative treatment. He has a severe tenderness around the shoulder joint and painful range of motion. X-ray and MRI shows calcific lesion in supraspinatus. Plan was arthroscopic debridement and repair of the rotator cuff. This is the arthroscopic video. First diagnostic arthroscopy done in a glenohumeral joint, which is usually normal. In the subacromial space, there is a lots of sign of severe bursitis, inflammation, and hypervascularized tissue. Thorough debridement is necessary before proceeding for debridement. Identify the calcific lesion with 18-gauge spinal needle and decompress it. Calcific deposits and dead tissue removed with shaver and use of radio frequency. And debridement done up to healthy cuff tissue are found. Video length. After the debridement, put a suture anchor and repair the torn part of the rotator cuff. Next. Okay, in conclusion, calcific tendinitis is a self-limiting disease. Surgery is indicated when conservative treatment is failed to control the pain. Thanks.
Thank you, Rohit bhai. So I would ask Dayanidhi Sahib and seniors who have seen this probably calcific tendinitis since many years, then we have even started to spell it out. What are their experiences? Because probably we have more to learn from their experiences than ours.
Generally, when we come across this type cases, anti-inflammatory injection or at the most steroid injection. That solved the problem. And I have till in my 40 years of practice never seen a need to do this arthroscopic. At the most we have to do aspiration. It is not required.
So, friends, we have with us, and the next topic again is very pertinent to all our orthopedic friends. It is how to manage a first-time dislocator, because it is always a firing discussion on all the arthroscopy meetings. And to present that, I invite Dr. Inderdeep Singh. He has flown all the way from Amritsar. He is a executive committee member of Indian Arthroscopy Society. Thank you, sir, for being present in this meeting. And I would like to have more inputs from orthopedic surgeons regarding how their experiences, honest experiences with first-time dislocators.
Dear colleagues, it's my pleasure to welcome you all to the Ias One program. The presidential theme of the Indian
Arthroscopy Society this year is Bridging Boundaries. With this vision,
there is a short message from our probably IAS President, Dr. Arumugam sir.
Ensuring that arthroscopic surgery is
accessible to all.
The IAS One initiative was conceived to realize this ambitious goal. Today, I also wish to encourage our young surgeons to join the IAS family. Membership in IAS comes with a multitude of benefits that are invaluable for your professional growth. As a life member, you will gain access to your own personal digital secure logbook, which is the IAS Ligament Registry. Our knee registry is among the best globally, and we are soon launching the shoulder registry. Additionally, we have significantly increased the number of IAS inland and foreign fellowships. These fellowships provide an exceptional opportunity for members to enhance their skills and knowledge. By becoming an IAS member, you can apply for these prestigious fellowships and gain unparalleled exposure and experience. Moreover, we have expanded the number of IAS accredited training centers across the country. This ensures that high quality training is available to you at a location convenient for you, thereby supporting your continuous professional development. As you engage in today's program, I wish you a day filled with rich learning experiences, vibrant interactions, and of course, a bit of fun. I extend my thanks and appreciation to the organizing team for conducting this IAS One program. Long live IAS. Jai Hind. Dear colleagues,
So the dilemma always is how much time we should immobilize a first-time dislocator. The dilemma is how we should immobilize the dislocator. So over to Dr. Indradeep sir.
Yeah. So good morning everyone. Thank you organizers for having me here. So it's a great opportunity, and I feel delighted to see every one of you here and participating in this academic event. So basically the concept of IAS One came in to spread the academics regarding arthroscopic and the surgeries which are related to arthroscopy, regarding even the basic arthroscopic procedures to tier 2 and tier 3 cities, so that no one is left out, because otherwise we have to travel all the long way to different distant cities to learn arthroscopy. And as the injuries are picking up, and so the treatment is, so our knowledge is. So it's great to see every one of you here to participate in this event, this single day meeting, and I congratulate the organizer, Dr. Kunal, basically. So he's taken a lot of efforts to organize the show. So the basic concept is like to deal with the basic pathologies which we see regularly in our OPDs. And at times we are, as he said, we are in dilemma what to do now. So I would like to know, I can have a show of hands. So whenever you see a first time dislocator, how many of you jump in and go for surgery, or and how many of you think I'll conserve this patient? Can we have a people who go for conservative treatment? Can we have show of hands? Great, great. So the job is half done. So I think so. Let's move on. I'll not keep this as a simple talk, but I would like to get some input from you as well. So to make it as more interactive session. So I will have some case scenarios. So this is a 22 years old. He's a right hand dominant club level. He's a bowling all-rounder, and he dislocated while fielding in one of the district's match. So that's how he came to us with a dislocated shoulder. So whatever we did as an orthopedic surgeon, we just went in, did it this was the first episode of his dislocation, so we reduced it in our hospital. So anything next, out of these 39 unstable shoulders, only 18 required surgery, while out of 51, only one needed a rotator cuff repair and one needed an instability surgery. So it's always a fair better to give them a chance to redislocate, or maybe better to have a conservative treatment in these patients. So again, if they looked at a 40 years or patients who are 40 years or older, so they had around 41 patients, in which out of these 4 were patients who were only unstable and 37 were stable. So out of these 4 unstable shoulders, just one needed a rotator cuff tear, no instability surgery again. And out of these 37 stable shoulders, they had only 7 patients who needed a rotator cuff repair, and 1 patient who did instability surgery. So basically, these can be fairly conserved, but at the same time, they should be under the observation. So they have less indication for surgery in patients who are like around 3rd decade, 30, 35 years old, but they definitely promoted to have a limited indication for surgery patients who were younger and who were athletic. So surgical stabilization again is a option which is the pendulum has shifted towards the surgical stabilization of late, with the latest research coming up. But if we look at the rate of recurrence, even after the surgical stabilization was around 29%, and there was no difference with respect to return to sports in these patients. So whether to do a delayed or an acute stabilization. So it all depends upon the host factors, whether we have to do an delayed stabilization in a first time dislocator. So it depends whether on the time of the sporting season, or eligibility, and the family pressure, the parents pressure, and future athletic prospects. And also, many papers have shown that there's low recurrence if we do an delayed or acute stabilization of the shoulder with an improved patient PROMs, and even event-free survival, and better return to pre-injury level in athletic population. So if we look at a treatment algorithm which was given by Albert Lin group in 2021, so for any first-time dislocator, look at the risk factors: age, hyperlaxity, and the contact sports. If you think there is less than one of the recurrence or less than one of these factors, you can always try a non-surgical treatment. But if there is any of these risk factors, you go ahead and investigate. Look for the bone loss, look for the soft tissue status, look for the Bankart's, Hagel, or what all the variants for these instability. So always sit back and talk to your patient, tell them all the pros and cons of your patients, so that they can have a better outcome and they can understand the pathology on being dislocating first time. So to conclude, in older and non-athletic patient, one can always give a fair chance to a conservative management. In younger athletic population, we can always go in for early stabilization. Because it takes 3 years for surgeon to learn when to operate, but more than 20 years to learn when not to operate. So that's what we have to learn. At the end, I would request, let's generate our own data. Let's become an IAS member. Whosoever is not an IAS member, please go to the IAS website and become an IAS member. And we have a Indian ligament registry which is pertaining to the knee surgeries. And please start uploading your cases onto it. We can have our own data The shoulder registry is coming up by probably this ISCon. It will be launched in this ISCon in Bangalore. So I request everyone to join into IIS to let's generate our own data, our Indian data, to tell world that we are doing a lot of work. So and tell that we are also something. Thank you so much.
Thank you very much, Indradeep ji. So I think the take-home message is to do not hesitate and investigate even the first-time dislocator if they are young,
Yes.
and probably go ahead with intervention if indications are so.
Yes.
So I would request Dr. Jignesh Pandya Sahib to felicitate our guest, Dr. Indradeep Singh. And I would also like to have his views, how he manages his first-time dislocator and he sees so much of trauma. So before felicitating, please your views, sir, on first-time dislocator.
Before few years, we used to treat all conservative, but now with recent understanding and lot of information, we now, young people, we always investigate and try to find out reason.
Mic चालू करो.
Hello. Okay. But now young individuals under 25 years or active people with sports activities, we definitely investigate further and find out that chance of recurrence are high. Then submit them to surgery. I refer to arthroscopist.
Thank you, thank you. That was insightful. So I think next is Dr. Devesh Shah from Ahmedabad. Now moving to the AC joint. Again, a very common topic in OPD, AC joint pain. And his case is specifically on AC arthrosis. Dr. Devesh is budding arthroscopic surgeon from Ahmedabad.
So good morning everyone. Thank you South Goa Orthopedic Society and IAS for inviting us and arranging this beautiful meet. Probably my topic is not that a main course, but it is a side dish. But believe me, this kind of cases are very common in our practice, probably more than rotator cuff and this labral pathologies, but they are very much neglected. Okay. So I am presenting a case, a prototype case. How do patient present with us and how we can manage it? So he is a 38-year-old male. He is a gym freak. He used to carry 10 kgs of heavy weight with dumbbells, and he used to exercise routinely up to 30 minutes to 1 hour for last 2-3 years, and now he has started complaining pain over the shoulder joint. So on examination, what we find is there is some tenderness over the acromioclavicular joint, and patient is having a diffuse pain over the shoulder, and the pain is also vague. And when we examine, the cross arm adduction test is positive, and possibly the terminal external rotations are also positive, and tenderness is elicited during the terminal movements. He has been given consultation at various places, and on the first consultation, as routine, what we do, we give NSAIDs, then some has prescribed physiotherapy in the form of ultrasound heat, isometric exercises, and have advised for stopping the gym exercise. Then patient had minimal improvement, and then pain again it comes. So he went to another consultant, and what he did was to start with a 3 months physiotherapy protocol. He had bluntly given the protocol that you should do 3 months physiotherapy, and then we will come back and see. He had started bisphosphonate, calcium, vitamin D3, and injection Canacot in the acromioclavicular joint. This Canacot works nicely, and he was pain free for about 1 month, and then pain again reappear. So I'm just showing the x-rays, what the x-rays were showing. So the acromioclavicular joint was seen quite nicely, and there were no much arthritic changes over there. Mild this lysis over the distal clavicle and small osteophyte over inferior aspect of the acromion and clavicle. In the Y view also, there is no major impingement, which may rule out the pathology for impingement. So he had been advised for an MRI, and MRI was just showing a hyperintense signal at the distal end of the clavicle with mild osteophyte and margins uh, in both of the views. So what was the plan of the treatment which I had decided? So already he had been advised a good protocol for physiotherapy as well as medicines for such 6 months, and now I had planned my surgery in the form of distal and clavicle resection. So in this surgery, after viewing from the posterior regular portal, we find the subacromion space, and we find the this acromion above. We just resect the bursa and clean the undersurface of the acromion. I will like to show the such a stepwise approach. And because cuff is intact, it is very difficult to visualize whole of the acromion. So we have to move very gradually, ablating the bleeders. Then I shift to little posterolateral portal for the proper anterior view of the acromion. By palpating the clavicle from above, you can see the ballotment and identify the AC joint. Then for the anterior portal, you pass the needle just 1 to 2 centimeter below the clavicle and find a perpendicular trajectory to the acromioclavicular joint. And after shaving off the soft tissue below the acromion, I mean the distal end of clavicle, we identify the joint and ablate it with radio frequency ablator, and again checking exact location of the clavicle. Because we need to stay within 2 centimeter of the AC joint to preserve the coracoclavicular ligaments, it is very much important that you should not migrate to medial aspect. So repeatedly ballotment of the lateral end of clavicle is required. Then the process of burying off of the distal end of clavicle is started, and this has to be very meticulous and slowly step by step. In my case, I had done this a distal 8 to 10 millimeter of resection only. You should watch the cancellous bone, how it's getting burred off layer by layer. You may need to shift the trajectory of the burr to get a perpendicular plane while it's getting burred proximally. when we reach to almost 70-75% of the erosion of the bone, then it has to be very slowly to preserve the superior periosteum. So after burring off and you find that the cancellous bone is no more, you will find some white shiny fibers. They are the part of periosteum, and you should not excise them completely. With the help of a probe, you should check the consistency of the tissue, if it's solid or it's ballotting. So the part which is a solid one, you should again burr it off and preserve the soft white tissue fibers. The anterior most fibers are not possible to get burred off from the anterior portal, so you may use a Naviator portal for the same, and I will use the same for burring of the anterior aspect of this distal clavicle. Slowly the bone is getting off, and only a thin anterior margin is left, which I will excise from the Naviator portal from posterior aspect. After almost finishing the resection, we will ablate all the margins with radio frequency ablator for burning out the free nerve endings and elevating the pain. And you have to take care that the margins are not very sharp, so as to prevent the impingement of rotator cuff over there. And finally, this ablating the surrounding tissue and free nerve endings. So this is not 1.2 centimeter resection, it is a 1.2 centimeter gap. It was almost 8 to 10 millimeter of the resection of distal end of clavicle. And this was the pre-op, and this is comparatively post-op view. Thank you.
Thank you very much, Daivesh. AC joint is not as uncommon as we think in our OPD. AC joint pain and MUFO definitely serves the purpose. Do you inject local anesthetics and diagnose?
Yeah. Every time I inject Kenacort cortisol, maybe Depomedrol Kenacort in the AC joint, and then wait for the symptoms to relieve. If they are not relieved, then I proceed for the distal and clavicle resection. Osteum. And so that is a bridge between the distal and clavicle and acromion. So there is no much power loss, and there are two papers. One is by Snyder and one is by Peterson. So they both tells that 87% of their patients have again gained the same power which they were having before operation. Yeah.
So initial rehab, when you give them initial treatment, so in a rehab, what are the major exercises which are included in your protocol? Do you look upon them or your physio take over? What are the particular exercises you would like to guide them that these are the exercises I want?
Literature is also not very clear about which exercise should we do, but it's like to maintain the mobility of the joint and maintaining the cuff isometricity, we just give the stretching exercises and isometric exercises. There are no specific exercises for AC joint in the literature so far.
Most of these patients have imbalanced scapula. So probably balancing the scapula may work along with the...
That is one of the things that you have to stabilize the scapula. And when you see such MRIs, you will find cuff tendinopathies, partial supraspinatus tear, some slap lesions, partial fraying of the labrum. But this particular case, I want to show that when you see the MRI, I was also I was also expecting a slap tear in this lesion. So what I had done was I had injected lignocaine inside the joint. After injecting the lignocaine, because he was having pain in the O'Brien test also, and he was not able to throw also something. So I was just skeptical if the patient could have the slab also, because MRI, when you see this, you can see this white hyperintensity at the insertion of this bicipital groove. So I was thinking that patient must be having slab, and radiologist had missed it. So what I did was to rule this out. I had injected lignocaine both at the AC joint once, and then again in the second visit I had injected in the joint, so that I can differentiate between the pathologies for what patient has come to me. Okay, and in arthroscopic findings also there was no slab there.
So thank you, Devesh, for that insight. I would like our Secretary of SGOA, Dr. Mubin Kazi, to please felicitate Dr. Devesh Shah. Thank you, Mubin Bhai. Thank you, Devesh. Next is a very interesting case by our own Dr. Bharat Sutaria. He is a post-ORIF proximal humerus case. And before he takes the dais, I would like to invite Team Seronics. Seronics has always supported medical education in arthroscopy as far as India is concerned. And now they have taken a big leap in supporting Indian Arthroscopy Society for promotion of this Ias One in second tier. They are always very advanced in research and development. So I invite our President, Dr. Nilesh Bhai, to please felicitate Team Seronics. Thank you, Seronics, for supporting this event. Please. Thank you, sir. So now, again, a very interesting case.
Chalu. Okay. Good morning, all. My case is slightly different than arthroscopy. It is about trauma. Now, I had this patient who had been operated for proximal humerus fracture fixation. He is 49-year-old. He is having a severe pain in a left shoulder with tingling and numbness in a left upper limb. And on an examination, I could not able to examine the deltoid power because he is having a severe pain. But he is having around grade 2 biceps power and grade 3 triceps power. Finger power are normal, but there is a loss of sensation all over the lower part of the forearm and finger. So let us start with the trauma. Manoj bhai, આવું આવે 3 મહિના જૂનું પ્રોક્સિમલ હ્યુમરસ શું કરશો પહેલા દિવસે આ એક્સરે જોઈને? So you will like to have a further investigation. One is a okay. No, it's severely painful. Yeah, it is restricted and painful. It is just I can able to do it passively up to 30-degree abduction and very hardly any rotation. Rotation was hardly, it was around 10 degree. So it was stiff shoulder. નહીં પણ ડિસ્લોકેશન તો તમે સિટીમાં જુઓ ને અહીંયા છે જ ને.
That is right, it is not holding. According to your examination, in which dermatome or this thing, the hypoesthesia and tingling numbness?
Sorry, sir.
On examination, in which dermatome they
C5,
changed.
6, 7 and T1 બધામાં જ હતું સર અને મોટર બી છે.
So EMG will tell something that is a
So
brachial
I'll show you
plexus
the
problem.
EMG. This is a EMG report.
Parabrachial plexus plexopathy. It's an ongoing degeneration.
No, it's a brachial plexus is far away. Where is the spine?
How was the injury? Road traffic accident.
He was having a road traffic accident, yes.
And there was no immediate after trauma, there was neurological symptoms.
I do not, when I read the paper of the discharge card, it was mentioned there is no neurological deficit at the time of a injury. When I asked the patient, he was saying that I did not have any kind of a tingling numbness in my upper limb at the time of the trauma because he has been operated on the next day. So he could recall કે એ દિવસે મને કઈ વાંધો નહોતો, તરત સર્જરી નહોતી થઈ.
The subluxated head is giving traction on the brachial plexus. Is it possible?
Possible, everything. હવે ચલો reason, now what will you do? 3 મહિના ongoing degeneration brachial plexopathy, very poorly fixed proximal humerus with metaphysis, extension, 4 part and a 49-year male. Now the option. Chetan bhai, option. Yes, Pav.
We'll do repeat EMG. If there is a sign of reinnervation, and I would like to take opinion of brachial plexus surgeon. If he is going for some surgery for the brachial plexus, we'll refix it and with the guarded prognosis.
No, but at the 3 month, you'll ask the patient to wait for another 3 months and do the EMG and see, then you'll take a decision.
This is a fresh EMG or it's a old EMG?
This is at the time when patient came to me on the same day. So, ત્રીજા મહિનાની EMG and CV છે તો patient ને શું સમજાય કે 3 મહિના પછી આવજો EMG.
No, I'll take the opinion of brachial plexus surgeon and depending on his prognosis, I'll go ahead with the fixation of the humerus.
So you meant to say if you take a opinion of a brachial plexus surgeon, if he is positive about the recovery, you will do the re-osteosynthesis.
Yes.
Okay, option 1. Any other option then, Pawan? Kunal, આમાં કઈ replacement નું થાય? So first, આની સાથે કોણ એગ્રી છે? Wait and watch. So you are for wait and watch. Pain was manageable. Replacement માટે later માં કે main અત્યારે જવા દે. So head was out. The Priyank was right. None of the screw was in the head. It was subluxated. એટલે અત્યારે છોડી દેશો તો he will definitely have something later which will be a reconstructive surgery. I mean replacement surgery than a reconstructive. Yes. Right, sir.
The fracture requires intervention. But by intervening, you do not give him any good prognosis that you will have a good recovery.
Right, sir.
Because the neurology may or may not recover. If you don't enter now for the fracture, the other options due to waiting will be more difficult at 49 years of age.
Okay.
So you go in, you operate, but the prognosis is guarded. You may not have recovery. And if he agrees, then you operate. Otherwise, you.
So how difficult right now? Let us assume we'll keep a neurology aside. What do you think? How will you reconstruct this operated proximal humerus at the 3 month with this fixation and this fracture pattern? Neurology will, let us keep a neurology aside. આને ફરીવાર ફિટ કરવાનું છે 3 મહિને. નો હું સર જોડે એગ્રી છું. મેં એવું જ વિચાર્યું, પેશન્ટને સમજાયું કે ન્યુરોલોજી જુદું છે, ફ્રેક્ચર જુદું છે. આપણે ફ્રેક્ચર ફિટ કરીએ, જે બી મળે ન્યુરોલોજી જોઈ જશે.
જરા મિસ આઉટ થઈ ગયો, એક્સરે બતાવે.
ચલો, I'll refix it. I went inside, I split the GT, LT, I put a bone graft and this was my post-operative X-ray at day 1. Jignesh bhai, read the X-ray and tell the prognosis.
It is subluxated because of the weakness of deltoid and the rotator cuff because of neurology problem. And your platelet is a little bit high, but impingement नहीं आता है, तारा काढ़ी नाखवानी.
नहीं, but
plate I will use little bit longer plate.
નહીં પણ સપોઝ પેશન્ટ આ એક્સરે લઈને તમારી પાસે આવ્યું કે આ કાલે અમે કરાવ્યું અમને આ ઓપરેશન
તમે બીજે દિવસે પાછો રિવાઇઝ નહીં કરીશ બીજે દિવસ થોડો બેસવાનું જવા
નહીં પણ તમે એને સમજાવશો શું તમે what do you expect from this x-ray કે આનું શું થશે
I will ask him to wait. Mostly should unite. This fracture should unite. Union should occur. This is okay fixation, protect, okay, and wait for the neural recovery as well as the fracture union.
Okay.
This looks good.
Okay. No, it's not about head. I'm asking about the fixation itself also. દેવાંગ આ ફિક્સેશન કેવું લાગે છે તને પહેલા દિવસે તને પેશન્ટ તને લાગે છે
કરતા કરતા વિચારો કર્યા પછી તો હવે એક્સેપ્ટ જ કરવું પડે
એક્સેપ્ટ કરવું પડે
બીજે દિવસે થોડો નવી પ્લેટ નાખવા બેસવાનો
પેશન્ટ ને કંઈક તો સમજાવવું પડે ને તમારે એક્સેપ્ટ
હવે એવું કહું કે સાહેબે કર્યું છે બરાબર સાહેબને પ્રોટેક્ટ કરવા પડે ને
ચાલો 3 મહિના પછી
ચોંટી ગયું છે ચોંટી ગયું એવું લાગે છે
ચોંટી ગયું
ચોંટી જવાનું
અને ન્યુરોલોજી બી રિકવર થઈ ગઈ હેડ બી ઉપર આવી ગયું યુનિયન બી થઈ ગયું 6 મહિના
એટલે હવે પ્લેટ ઉપર આવશે તો નડશે
વિડિયો પ્લે કરતો હે
હવે હેડ ઉપર આવશે ને તો નડશે પ્લેટ ઊંચી છે ને એટલે
નથી નડતી વિડિયો પ્લે કરને ત્યારે લાગતું તું નડશે પણ નડતી નથી
નસીબદાર છે
પ્લે કરને
કરો ઉપર ઉપર કરો ને
ઊંચો કરશે એટલે ખબર પડી જશે એનીવે થેન્ક યુ ચલો આ તો ખાલી ટ્રોમા વાળાને જરાક પેલું આર્થ્રોસ્કોપી જોઈ જોઈને બોર થઈ જાય ને એના માટે હતું
આ આર્થ્રોસ્કોપી માં અમને બોલાવે
બાયસેપ્સ કાપી નાખ્યો તમે વચ્ચેથી એટલું ફાઇબ્રોસિસ હતું વચ્ચેથી કાપ્યા વગર જવાય જ નહીં ને આટલું 3 મહિના જોડું એટલે બે એલટી જીટી જુદો કરે બાયસેપ હા કદાચ થેન્ક યુ
Thank you very much, Bharat Bhai, for waking people up. And I request Dr. Ritesh Bhai Patel to felicitate Dr. Bharat Sutaria. So next is again a case from trauma only. Dr. Rahil Vora, Team Ritesh Bhai, presenting a case on GT avulsion fracture and their own way of managing GT avulsion.
Good afternoon, friends and respected senior, and thank you so much, South Gujarat Orthopedic Association, for giving me this opportunity, and also special thanks to my mentor, Dr. Ritesh Patel sir, for giving me this opportunity on the dais to present a case on GT avulsion fracture and its fixation. I will present a case, open GT avulsion fracture fixation with double row suture bridge technique and anatomical GT plate. Let's start with the case. We have a 72-year-old male patient, history of fall down from bike, having left shoulder pain. He was unable to move the shoulder, taken the primary treatment somewhere else. It was fracture dislocation, and fracture dislocation was reduced under general anesthesia, and x-ray taken. Then post reduction, patient came to us. These are on the clinical examination. He has drop arm and drop arm present, and movement was painful, but passive movements all are okay. Uh, this was his X-ray, fracture dislocation, and this is a post-reduction X-ray. We get the further investigation done, CT scan done, as a 72-year-old with high suspicion of after as Dr. Swapnil sir and explained that it has a associated, probably it is associated with rotator cuff injury. So we get only the CT scan done, and this was it's a CT scan. We also get the glenoid done, glenoid 3D reconstruction done to rule out any Bankart lesion, bony Bankart lesion. So what are the routine treatment option? We can do the open reduction and the Philos plating, or as in the routine, or in the last couple of months, due to Philos is high profile plate, bulky, so for only GT fracture, uh, some of the surgeons are doing now small locking plates using like lower and radius plate, Ellis plate, or we can do just simply the do the open cuff repair, or if fracture fragments, GT fracture fragments are big enough, and then we can do the percutaneous screw fixation, or sometimes if surgeon is confident, he is arthroscopic surgeon, then he might do the arthroscopic GT fixation. But here we did open GT fracture fixation with double row suture bridge technique and anatomical GT plate. These are pre-contoured plate with inclination according to the anatomy of the GT, and it fits well with the it fits well with the rotator cuff insertion, as we can see in this picture. And these plates are according to the side, right and left, so it fits well. Fixation was done in beach chair position. Anterolateral deltoid split approach was taken, which is around 5 to 7 centimeter in incision size. Point fixation was done with 2 medial row anchors, metallic anchor, triple loaded in the base of the fracture, and point fixation done to repair the cuff. After that, GT fixation, primary fixation done with the K-wire, and plate was fixed, and 2 lateral low anchors were used alongside the GT plate. This is a post-op X-ray. This is a serial follow-up X-ray. First X-ray is at the 15 days, and another is at the 1 month follow-up X-ray. Post-op protocol, we put the arm in pouch arm slings, and no shoulder immobilizer given, and pendulum exercise started as pain permits, and scapula bracing exercise, table slide exercise, very big chunk of bony Bankart. And sorry for it is not a proper clear images for the MRI, but it has a massive rotator cuff tear with subscapularis upper fibers tear. Video. This is the clinical video of pre-op. we did the massive, it has a massive rotator cuff tear with supra and infra with superior fiber tears of subscap. Arthroscopy, we did arthroscopically bony Bankart repair with massive rotator cuff tear repair on beach chair position in the same setting. Bony Bankart was repaired with two soft anchors and massive rotator cuff tear was repaired in standard double row technique. We also repaired the subscapularis also. Important message here is injury to surgery interval. It is less than 10 days. In this case, we operated at the 8th day. Sometimes it is necessary to intervene patient early rather than to wait for the multiple dislocation. These are intra-op images. First is subscape. For this is bony Bankart. We repair the Bankart with two soft anchors. These are repaired. This is subscape. We repair the subscape, and this is repaired cuff. Video. Patient has excellent outcome at the end of 6 months. We follow the same post-op protocol. First month of passive exercise, no active exercise, and shoulder arm sling for at least 2 months. But patient can remove and do the exercise. After first month, active physiotherapy is started, and it is under watch from the. It is physiotherapy is always under watch of us, because it is very important to, if patient makes any mistake, we can correct as early as possible. Okay, thank you.
Thank you very much, Rahil. That was a wonderful presentation of a difficult case. Questions from the floor for the shoulder instability cuff tear with bony Bankart. So I would like to invite Dr. Nayan Bhatt to felicitate Rahil. So continuing the spectrum of trauma, Pawan is here, Dr. Pawan Desai is here to present a case on floating shoulder.
So, good morning everyone. I'm going to present a case of floating shoulder. The uniqueness is it's a compound injury. So as you already know that floating shoulder, it's a high energy injury with fracture of the scapula neck, ligament disruption with or without clavicle fracture. If patient is upright, the affected limb often hangs lower than the contralateral side. So this is the ring shoulder, superior shoulder suspensory complex. The ring is formed by coracoid process, CC ligament, lateral end of clavicle, AC joint capsules, and the coracoacromial arch. So if the ring is broken, then the diagnosis of floating shoulder is made. So our is a case of floating shoulder. One can see there is a fracture of posterolateral acromion with dislocation of AC joint. So in our case, a two-wheeler accident, floating shoulder injury, fracture of acromion with dislocation of AC joint, massive soft tissue injury with rupture of deltoid and trapezius fascia. This is the clinical picture. It's an extended saber cut injury. One can see drooping of shoulder. And this is the CT scan, fracture of posterolateral acromion with AC joint dislocation. And this is the video. Please start. It's a video from CT scan console. The fracture of posterolateral acromion and AC joint dislocation with clavicle has been subtracted by the technician. So we do a thorough debridement with open reduction internal fixation of the posterior acromion with 2.7 reconstruction plate, and we were contemplating how to fix the AC joint. The routine standard protocol was to do a tension band wiring, but we chose to do suturing of the AC joint in the following method: drill hole in the lateral end of clavicle, another drill hole in the acromion, suture shuttling of fiber tape through it, and not tying over the bone, additional fixation with the SS wire from the another drill hole medial to the previous hole, and suturing of AC joint capsule, suturing of deltotrapezius fascia was done. This is the intraocular image of the plate with the suturing tape. This is the post-op wound, and this is the X-ray. I would welcome the any criticism from the floor.
Yes, any comments by the trauma surgeons specifically? Bharat.
Yes. Okay. Yeah, because the distance preoperative, if you see the preoperative X-ray, the distance was normal. The CC ligament distance is normal. It's only a sharp cut injury of the AC joint. So the AC joint was dislocated. Considering the space preoperatively was normal, and we have not touched it. Yes. Yes, yes.
There is a very important point that it was a transaction through the AC joint,
AC
and actually CC ligament was preserved. So this point has to be on consideration for all of us.
Thank you.
Thank you very much. I would invite Mr. Shiv Acharya to felicitate Bhargav. Dr. Manoj Narang, can you just come in front and felicitate Pawan? Next and probably the last case is from Dr. Vishal Mandlewala. Again, a very common OPD problem which we all face, adhesive capsulitis, frozen shoulder, and he has some novel technique of dealing with those patients with good results, good outcomes. So, would like to share his experience here.
Thank you so much, Ias One, SGON, and Kunal sir for this opportunity. There are always a frozen shoulder. There is a debate that what's the ideal mode of treatment. Either it is conservative with physiotherapy, or conservative physiotherapy and steroid injection. So here I present my case in which how I proceed in a frozen shoulder patient. So this is a case of a 40 years of female, left shoulder pain. She had a history of diabetes and shoulder range of movement were restricted. So this was the range of movement of the patient when she had came to me. 3 months of she had a history of a shoulder pain. The movement was severely restricted. Even the passive range of movement was restricted of this patient. So how to proceed in such case? I always prefer that we should get an MRI done. The reason for MRI is because along with the frozen shoulder, sometimes it may be affiliated with a shoulder arthritis. There might be a partial rotator cuff tear, and it can be also calcific tendinitis. So we always need to be sure that we are treating only a frozen shoulder, not any other etiology along with it. So how do we proceed if such case scenario? Only medications, but medications in frozen shoulder it won't work. Medications and physiotherapy, yeah, physiotherapy might work because it will help to stretch the capsule, but sometimes the pain is so severe that patient won't allow the physiotherapist to do a physiotherapy. So a Canacon injection can be given along with medications and physiotherapy. So in my practice, I advise them that you take an injection, do a physiotherapy for 1 month, but after 1 month, you should have at least 20 to 30% of relief. even after 1 month of physiotherapy, after injection, there is not 20 or 30% of relief. There is no increase in pain of movement, or decrease in pain reduction. It is very unlikely that they are gonna recover quite well, and patient ideally comes back to me within 3 weeks. Some of the patients do recover, so in those scenarios, we continue the physiotherapy. But if the patient do not recover after 1 month, then what do we do? Do we again give an injection and the same procedure continues? But in my opinion, that giving another injection is not going to help. I do in them a hydrodilatation. So the things which we require while doing hydrodilatation, like 100 ml of normal saline, uh, extended cannula 100 centimeter, then a Canacort injection along with local anesthetic, and 18 gauge spinal needle. So 50 to 60 ml of normal saline is injected in the shoulder joint under CM guidance with the patient under general anesthesia and shoulder block. So after giving the injection, the glenohumeral joint gets dilated. If we see over here, before hydrodilatation, the space of the glenohumeral joint, and after hydrodilatation, the space has increased drastically. Because after dilating the joint, the capsule gets stretched out, and because of the stretched capsule, the movement of the increases. Play. So, play. So here, if you see, before hydrodilation, the range of movement of that patient was quite restricted, or immediately after hydrodilation, the full range of movement has been achieved. So ideally, if this patient goes for only physiotherapy or steroid injection, it takes maybe 6 months, or it might take a longer time, and all the patients will not be able to bear that much of pain. So it is ideal that if not recovered by injection or physiotherapy, then hydrodilation can be advised. Play. So as I shown before, this was the movement of that patient. And on the right hand side, this is 2 days after hydrodilation. So pain-free complete range of movement was achieved. So after hydrodilation, we have to take care that the recurrence of this frozen shoulder doesn't take place. So I advise them to do a rehabilitation of physiotherapy protocol for at least a month, so that the recurrence of frozen shoulder do not take place. This is a review article. The review article of 319 literature they have taken, which have they have concluded that hydrodilation with corticosteroid is the most effective for the frozen shoulder treatment. Thank you.
Thank you very much, Vishal.